Respected chairperson, are you able to see my presentation?
Yes.
Okay, thank you. My presentation is on the recent advances in extracorporeal circulation technology for better outcomes for pediatric cardiac surgery. Basically, for background of this presentation is pediatric cardiac surgery is itself very enigmatic and individualized type kind of situation. There are new development which have been recently developed, especially in this kind of gray zones. There are a lot of gray zones. As such, open heart surgery is a bit tricky also. So in this coming presentation, these are my objectives to give this presentation. Basically, to highlight the technical challenges and new developments, primarily towards CPB. CPB is a short form abbreviation I'm going to explain. It's a cardiopulmonary bypass. It's a bypass technique where we stop the heart and all of the blood goes to some other circuits to oxygenate, and mainly for safer application pediatric and unit patient. We have searched thoroughly recent publications from different databases, especially from PubMed, Google Scholar, and ResearchGate. This is a compilation of recent things which has been recently developed. These are the list of abbreviation which I am going to use. First, I have told you that is CPB, cardiopulmonary bypass, or we called it heart-lung bypass machine or bypass machine. Next is goal-directed perfusion or goal-directed therapy, GDT. Hematocrit, RBC, arterial line filter, ultrafiltration. Next is activated clotting time, ACT, thromboelastography. These are meant for coagulation profile testing. Next is rotational thromboelastometry. This is also a test for coagulation profile. DHCA is deep hypothermic circulatory arrest, DHCA, where we goes down temperature to below 18 degree to stop complete circulation. It's a kind of near death where we go down up to 18 degree of temperature and stop the complete flow. Next is nitric oxide. Nitric oxide is NO, and systemic inflammatory response syndrome is SIRS. These are the abbreviations which I am going to use. So there is a famous quote by Glenn Jacob: "Things are never simple when it comes to human heart." Especially it is also meant for pediatric age group when it is more difficult. So long time ago in 1800 and 1700, human heart surgery is near impossible. But recently everything has been developed. So we know well that for adults, cardiac surgery is a bit easy now, but for pediatric, there are some gray areas. Intracardiac repairs require CPV and definite specialized perfusion strategies. Perfusion means, I have told you earlier, so at that time heart is totally silent, is in diastolic arrest and opened up. So development of surgical management, new perfusion advancements have diversified the clinical setting and focused on causing more survival of neonates and children, especially for complex pediatric cardiac surgery. So these are the main topics which have been covered in this coming. One is goal-directed perfusion, flows and pressure, blood conservation, and discussion over that thing, anticoagulation management and their monitoring, inflammation and oxygen injury, and last thing is myocardial protection. After that, I am going to just summarize it. So first thing of this topic is goal-directed perfusion. Goal-directed perfusion it's a term originated from goal-directed therapy, which was first used by Dr. William Shoemaker in 1988. It focused on critical values. It gives basically in high-risk surgeries, it's a basic theory. If we give supernormal values of the nutrients, especially cardiac index, oxygen delivery, and maximal oxygen consumption, there will be less acidosis. There will be beneficial effects. So improving the oxygen delivery, it prevents anaerobic respiration, and it will create a more good kind of milieu to to stop the injury, further injuries. So this is the goal-directed infusion. So there is a delivery oxygen index which has been broken up, and as we can see, there is a tool that has been developed by Sarian et al. So it's a table which shows the BSA, body surface area, hemoglobin, and the ideal flow rates. So basically we correlate with them by the AKI, acute kidney injury, to correlate the oxygen delivery. And we found that perfusion, as much as the perfusion, if it's a good perfusion or adequate perfusion according to this chart by hemoglobin and BSA, there will be less chances of injuries. And further there is a less rise in lactate level, which also prevents morbidity and mortality. This is the concept of goal-directed perfusion. So there are the 5 guiding rules of implement goal-directed perfusion. We have to limit the hemodilution and CPB, hematocrit management, or we can say in a plain words, adequate hemoglobin. It should not be less than 7 or more kind of hemoglobin. So that will create a problem. Oxygen delivery index should be kept more than 270 milliliters per minute per meter square, and increase the DO2 by acting on the pump flow. And we have to oxygen delivery to carbon dioxide production ratio to be kept more than 5, and transfuse RBC based on the oxygen and SVO2, not on the basis of hematocrit only. So these are the 5 main principles, 5 guiding rules. So we have to give a kind of supernormal values of oxygenation and clearance, so that we create a better milieu for the prevention of injuries. Next thing, in this context, there are 2 articles by Mirla Bojana et al. 2018. They said that maintaining perfusion pressure above 60% of the normal age may provide effective renal protective strategies. And next is Vivian G et al. In 2021. Mean arterial pressure less than 25 millimeter mercury can lead to rise in lactate. As we know that lactic acidosis is quite harmful. So if arterial pressure is less, that is more problematic or more damaging. And same thing happens if, so we have to maintain adequate perfusion pressure. It should not be very much higher and it should not be very much low. Or we can say it on the higher side of the perfusion pressures. Next point is blood conservation. What are the target hemoglobin? Recently, there was no such clear-cut guidelines how much it has to be target hemoglobin. In pediatric surgery, I'm talking about the pediatric cardiac surgery. But recently, there has been consensus statement, hemoglobin 7 in the corrected pediatric patient and 9 in the uncorrected pediatric patient. This is corrected and uncorrected means in kind of surgery. So we can say hematocrit of 18 to 32. Routinely, it is taken as a, you can say 8 to 9 mg per dl, you can take. So minimum hematocrit on the CPB has to be 32%. 32% means roughly 10 hemoglobin. At the time of, while coming off from the bypass, it should be more at the hematocrit of 43%. So in current pediatric perfusion practice, initially that was 7 to 9, it has been raised to 10 mg per dl. This is the recent quotation from Annals of Thoracic Surgery in 2021. So next is miniaturization. Miniaturization means our that concept of CPV circuit to make it short. Make it short, what will it help? It will help in maintaining the neonatal oximeter with minimum priming volume, minimum additional volume. There are some branded Quadriox neonatal by Mackey Group, Capiox FE, 0.5, Terumo, Livanova, Medtronic, and Meadows H-Lite. So you can say there in this Mackey and Terumo, they have an integrated arterial line filter, ALF, that you can see with a maximum blood flows 1.5 liter per minute. That is adequate for neonatal and pediatric oximeter. And there are very less priming volume, you can say, only 40 to maximum in highlight 57 ml. That is adequate for roughly 0.38 to 0.39. So minimum level in reservoir is very less, and biocoating has been by softline, by polymerized and heparin. So these are the things. So these are the oxygenator with integrated arterial line filter. As I told you earlier, this is the ALF, integrated ALF. This is in Mackey Group and Terumo. So standalone of ALF, it takes almost 20% of the priming volume. So primeless filter wrapping around the hollow fiber membrane of oxidator. It lowers the primer and produces filter better than standalone. Standalone has two clear-cut advantage. So by lowering the priming volume or addition of the extra fluid to the CPV circuit, that helps in pediatric patients especially. There are some new concepts. There are primeless filter wrapping around the HFM, which is the second line. But this is a recent concept. It has not been established. Next is mouse mounting. Mouse mounting means because we can cut short the tubing length. As we know in the heart, when the heart is arrested, the whole of the blood comes through aorta, comes through the bypass, comes to that bypass circuit by both the venous cannulas. In the meantime, that goes by a circuit. So that by reducing the tubing length, and especially the sucker can be placed closer. So especially by reducing the tubing length, exposure of blood to the plastic coating tubing is less, so there will be less inflammatory response. So this is the thing which we go with mass mounting. So that's a new concept and which has been evolved recently and accepted worldwide. So these are the hemoconcentrator. Next is hemoconcentrator. So we can say there are hemofiltration with minimum prime volume and great rate of filtration. So in this, you can say there are some different type of pediatric hemoconcentrator, Hemocor HPH. This is copyright. That HPH Junior, HPH Mini, HPH 400, where membrane surface area is 0.09 to 1.1, priming volume from 8 to 8.5 ml, and ultrafiltration rate. Maximum ultrafiltration rate is 30 ml per minute to 140. It goes from neonate to adult. So ultrafiltration. Ultrafiltration is kind of, you can say, conventional ultrafiltration. It is used during cardiopulmonary bypass. It removes extra water and maintains fluid balance, because extra fluid or extra water can create pulmonary edema or third space loss. Next is zero balance ultrafiltration. It is used during rewarming phase, because we have to cool down the patient at the time of bypass. Later we have to slowly rewarm. So it reduces the zero balance ultrafiltration, reduces the inflammatory cytokine and correct electrolyte and acid-base balance. It is routinely used at the time of rewarming phase. Next is modified ultrafiltration. That's a post-cardiopulmonary bypass. It is completion of the surgery. It limit early and post-operative RBC transfusion. It's a kind of sales level kind of situation. When after the bypass, we can use it, and it limits our RBC transfusion blood requirement in post-operative patients. So nowadays, modified ultrafiltration is going away in neonates, which has been quoted by GI Field. Next is our anticoagulation. Anticoagulations are heparin and antithrombin. As we know very well, for this procedure, for cardiopulmonary bypass, heparin is the major drug which has been used, which has to be used, because otherwise blood will clot and everything will be, coagulum will be formed, so nothing can be done. So there is a thing called heparin and antithrombin. Anticoagulation effects of heparin are monitored by ACT, which we know that, which was developed by 1975 in Bull and co-workers. Heparin works through enhancing the AT's anticoagulant effects. And heparin 83, it takes 3 to 6 months for 83 to come to adult levels, from a newborn to adult. So in these conditions, higher dose of heparin are needed. So we have to take care about the adequate ACT has to be maintained. Routinely in adults, we go for 480 seconds. So there are higher thrombin generation. There are chances of more coagulopathy. So we have to keep vigilant about the heparin dosing. So there are some chances of heparin resistant. We call it HIT or heparin-induced thrombocytopenia also. So alternative, there is biliverdin, which has the potential to provide stable anticoagulation. In case heparin is not working, heparin resistance is there, so we can go for any other alternative like biliverdine. So there are some, these are the recent trials which have been quoted. So there are the double-blind randomized placebo-controlled trial by Edmund Hoste and Rebecca Shaw. So there are 40 infants of younger than 7 months. So there are supplementation of antithrombin 3 with that helps better. There is no increased risk of bleeding, and there are beneficial effects in post-operative bleeding and reduced generation of D-dimer. D-dimer is a precursor of venous or venous embolic phenomena and coagulopathies. So these are the things. So next is rotational thromboelastometry, rapidly detects thrombocytopenia and hypofibrinogenemia. These are the two tests, as I told you earlier, thromboelastography and rotational thromboelastometry. These are the new technologies which have been recently evolved. So viscosity of whole blood analysis with whole blood coagulation testing method can be done very easily, especially with polymerized fibrin and platelet. And they show the progression of coagulation even after the extrinsic activation. So this is another study. So ROTAM analysis during the neonatal cardiac surgery is a sensitive and specific, especially for thrombocytopenia and hypofibrinogenemia. And it can detect within 10 minutes, especially for platelet degeneration. So we can transfuse the cryoprecipitate. It can normalize platelet count and fibrinogen level. So ROTAM is quite beneficial testing. ROTAM, rotational thromboelastometry. The next is the thromboelastography. There is another article that was annals from ATS, Annals of Thoracic Surgery by Sirisha Imani and Vishnu S. Imani. So it has been also they have also concluded that lower MA rewarming is increased of perioperative bleeding. So they have also individualized the platelet transfusion therapy based on the thromboelastography testing. It may reduce the risk of bleeding with minimize unnecessary platelet transfusion, because there is another thing. If we more transfuse, it will be problematic also. If it is less transfusion, that will be a problem. So we have to keep in balance. For keeping this balance, ROTAM and thromboelastography tests are very, very apt. This is the same kind of thing that has been World Journal of Pediatric Congenital Heart Surgery 2018 by Scott and Robert. So there was 44 neonates included in that study. That is nearly as the same. Conclusion were nearly same. That ROTAM analysis during the neonatal cardiac surgery is sensitive and specific. So these are the functional testing, as we say, functional testing. That is the hemostatic therapy for pediatric patient based on the post-CPB. Thromboelastometry measurement reduce the post-operative blood loss, and it leads to less post-operative blood transfusion. And in a long term, we can say short intensive care study, short intensive care stay, shorter stay, there will be less chances of not only cost, everything that will be taken care. It will be better for the patient and system both. So ROTAM analysis, and this is the kind of thing that functional testing is very much apt, and it should be taken care. Next, we go from myocardial preservation. As we know, even something like cardioplegia, for my surgical flick, that I can say that plegia, myocardial preservation, that word is used as a cardioplegia. Cardioplegia is a kind of solution which is high in potassium. If it is high in potassium, it causes the arrest of the heart. So it causes cardioplegia, arrest of heart, and diastolic. So some fluid has to be given, which should be cold. By arresting the heart, it not only gives the arrested heart by giving the cardioplegia, but it also preserves the myocardium. So there will be less function, less demand of oxygen. So there are some cardioplegia solutions based on the principle of this ideal myocardial preservation technique. There are two kinds of intracellular and extracellular types of cardioplegia solution were tried, developed, and tested. So intracellular are first, I think most of the transplant surgeon must be aware of the HTK or histidine tryptophan ketoglutarate custodial and urocolin solution. Initially, they were only developed as a organ transplantation, but later that has been used as cardiac surgery also. But HTK may not be adequate for pediatric patient. There is some controversy about that thing. So most of the solution, extracellular, one is intracellular, as I told you earlier, that was HTK, which is not used in pediatric surgery and not recommended. There are some extracellular cardiovascular solution. That was St. Thomas, blood St. Thomas, and Delnido. These are the cardioplegic. They are comparable in terms of myocardial protection. But Delnido cardioplegia solution has been established in pediatric surgery because it is used as a single, less frequent, less volume. It is more suitable for complex repair. One shot of Delnido gives nearly 60 to 90 minutes of cardioplegia or heart arrest. But St. Thomas cardioplegia, that can be used in both adult and pediatric, but it works only for 18 to 20 minutes. So Delnido cardioplegia, by recent studies from 2020 onwards, it has been established for pediatric and especially for adults also now. It's a burning topic still, despite being this exact time, we cannot count it by stopwatch, but mostly it is 18 to 20 minutes for St. Thomas and 60 to 90 minutes for Delnido. But despite there is some gray areas still. So this is a study which claimed that single dose custodial may be inadequate for prolonged cross-clamping without myocardial perfusion in invalid. That was in 2020 Journal of Cardiothoracic and Vascular Anesthesia. So as I told you earlier, HTK or custodial is a brand name. So that is being not adequately tested or not, you can say, established therapy for pediatric or neonates. Next topic or next debate is a nitric oxide and bypass. Nitric oxide, as we know, it's a kind of gas which lowers the pulmonary hypertension. So there is a randomized RCT done by Christopher James, Johnny Miller, et al. By Intensive Care Medicine in 2016. It was published. It concludes the delivery of nitric oxide to the oxidative gas flow during pediatric pulmonary bypass reduce the chances of low cardiac output syndrome, but it varies. Especially it varies also on the age group and surgery complexity, because as we know, no two hearts are of same type. Even for repairs, we can't prefix. There may be some intraoperative surprises also. There is another article in World Journal of Pediatric Congenital Heart Disease in 2020. This has also concluded the systemic administration of nitric oxide, NO is nitric oxide, during the Norwood procedure. It has a myocardial protective effect, which has been established by troponin, which has been examined by troponin levels, but there was no clear-cut effect on post-operative recovery. Intraoperative, it has a protective effect. So they conclude there may be some larger sample size may be needed to show clear-cut clinical differences. But on theoretical basis, we can say nitric oxide administration will help and will prevent the ischemia perfusion injury. Next, for inflammation and cardiopulmonary bypass, there is a corticosteroids are the very much established therapy for any kind of anti-inflammatory phenomena. So this is for a children. There is an article in Annals of Thoracic Surgery which has been available online from 2020. So corticosteroid, they are having a favorable impact on post-operative fluid balance with shortening the duration of mechanical ventilation, but in a long run, it doesn't have any impact on mortality. But theoretically, it may be beneficial. But there are some chances of prolonging or causing some kind of infection. So there is a bit of a two-edged sort of condition. But if it is used as a short term or a kind of short therapy, the steroids can be of help in cardiopulmonary bypass induced inflammation, and it will prevent SIRS, systemic inflammatory response syndrome. So next is dysbiosis. As we know, dysbiosis intestinal barrier, it is exacerbated. It's a kind of inflammatory, super inflammatory condition. So as the pro-inflammatory gut bacteria will increase, so they will cause there will be another problems that due to that pro-inflammatory gut bacteria, which is beneficial in a normal person, but due to bypass, that can exacerbate and cause problems due to low immunity. So this is the same thing, metabolic fingerprinting of infants doing CPV. So there are some changes in metabolic pathways. If there are some changes, as we can preoperatively we can decide by the metabolic fingerprinting of neonates. So if there is a large metabolic shift, so cardiopulmonary bypass can be damaging. Specific metabolite, especially aspartate or methyl nicotinamide, differentiate sicker patient. So we can know which patient will have a turbulent course after post-operatively and which maybe have some benign course. To conclude this, the another thing which I want to highlight, pediatric cardiac surgery itself it is a bit enigmatic. But one international pediatric perfusion practice 2016 survey result are with me, which has been published in Journal of Extracorporeal Technology in 2021. So as you can say in this, there are some centers which has been highlighted, which has been replied. As you can say in India and China. In China, there was no response. In North America, South America, Australia, European region, and Russia, and one center in Saudi, they have responded for this thing. So there is a thing called number of perfusions present for pediatric cardiac cases by region in 2016. As you can North America, there is a 45% cases there were 2 perfusionists, and this is maximum in Central European regions, and Europe that is only 17% in Asian regions. So there are also 56% of 2 perfusionists for pediatric cases. This is the time from 17 to 17 hour, means in the daytime, how much pediatric perfusionists are available. So this is the another thing which is the in this survey they have found most of the time in Northern America, plasmolite A and 25% albumin they are using as a primary drug additives. Albumin, 25% albumin. Heparin is the heparin, soda bicarb, mannitol, calcium chloride. These are the standard drugs which has to be used by everyone. But plasmolite A is routinely used in Northern America, but it is less in Southern America. In European region, this is also less. So this is the type of ultrafiltration by the region. As you can see, as I told you earlier, in Asian region, they have never, respondents are very less, only 16. But pre-CPV and MUF, they are still using. And during CPV, most of the centers are using ultrafiltration. Same thing for cardiac region solution and delivery system by regions. In Northern America region, single pass is used. Single pass or del nido are using in most of the patient. In some patient custodial, only very less, 8% only. Most of the patients are having del nido. But in Southern America, they are using 50-50. They are also using custodial, and chances of injuries are custodial are more. But in Asian region, most of the time, custodial is not used. Custodial is a bit costly also. That's a cost is a factor. Not using in Asian region maybe. That's my hypothesis. In European region, custodial and St. Thomas are used. They are using del nido a bit lesser, according to this study. So as I conclude this, to take home message for pediatric and neonate, accept goal-directed therapy or goal-directed perfusion. So we have to maintain higher hematocrit and higher flows. and we have to miniaturization of the tubing, cut short extra length, test for ROTAM and thromboelastography for coagulability status, and myocardial protection. So there are some things which is still in gray zone, I can say. That is, one is GDP, which is a hypothesis, steroid use of steroid and nitric oxide. These are the things which are in gray zone. These are my reference. One of our article by Salim, myself, and also which has been published recently in 2012. And these are the major articles which I have taken as references. Thank you very much.